Hello, this is Dr. Ajinkya here. So today's video is all about the X-rays in ENT. So what are we going to do today is I'm going to be teaching you the X-rays in ENT from the exam point of view. So this video is going to be helpful for those who are in first MBBS, that's the minor MBBS batch. And those residents in the ENT department, the first, second and third years, the exam going. So I'll be asking questions in point of view of as an examiner, what questions come in the exams, what precautions you should take not to give wrong answers, and what basic structures of the anatomy you should know in an exam when it comes to X-ray. So let's start with the very first X-ray. I'm going to start with the X-ray in nasopharynx. So the X-ray that you see in front of you guys is the X-ray nasopharynx. So there are basic points where you start off with an X-ray. So the examiner is going to ask you to read an X-ray. So the first step you are going to do is to hold an X-ray in your right hand, or if it's on a view box, you're going to take a pointer and going to start saying the first point will be that this X-ray is of a lateral AP or a PA view. So the first point comes as a view. The second thing is the structure or the anatomy, what you see within the X-ray, you have to say that. And the third is that if any pathology exists in the X-ray, you have to point out to that. So the 3 points, first of all, is to point out the anatomy. Second, to point out the pathology, and if at all you're holding the X-ray in your hand, you're gonna tell it the view in which the X-ray is. So 3 points: the view, the anatomy, and the pathology. So this X-ray is a X-ray of nasopharynx. So this view is a lateral view of X-ray in nasopharynx, showing mostly the adenoids. Now, how do you identify the adenoids? The second question, if the examiner is going to ask you, is that where do you see the adenoids? Okay, so as an MBBS student, you should know exactly if you identify the X-ray correctly. The second step is to identify the area of the adenoids. Now, there are two methods of easily identifying the adenoids over here. See my pointer out here, that's the area of the adenoids. Now, how are you going to find it? How are you going to find the adenoids? Now, let me just zoom in this picture. Now, look carefully. Now, you see this? This is the nasal bone, right? That's the nasal bone, and that's the area of the frontal sinus, and this is the area of the skull base, right? So always remember this white line which you see just adjacent to the frontal sinus, and as you keep on following behind, this area is the area of the skull base, okay? And you see a U-shaped cup depression over here, okay? You see that U-shaped cup depression, that's the area of the pituitary gland. So that's the sella turcica, okay? So the moment you see the sella turcica over here, this entire area is the area of the sphenoid sinus, okay? So as we all know, you draw a line vertical through the sella turcica, okay? You can see my mouse, the pointer is like vertical. So this is a sella turcica. You draw a line perpendicular right up to the lower aspect, and in this same axis should be your adenoids. You see this shadow over here? So it is below. So first step is to locate the sella turcica by the help of the skull base. Second step is to locate the sphenoid sinus, and the third step is to draw a vertical line through all these two structures. The adenoids should be right below it, okay? That was the first method. The second method is that you can see this is the area of the mandible over here. Now it's very easy for a student to identify the mandible, right? So this is the area of the mandible. It's quite visible, and the area where the mandible just ends near the ESC. Now you can see this area my pointer is pointing out to. That's a black hole. That is the external auditory canal, and this is the mandible area, okay? So this is the mandible area in the same line as that of the external auditory canal should be your adenoids. Okay, that's a soft tissue shadow. That is the area of the adenoids. So this is how you can easily identify the adenoids in a case of a X-ray nasopharynx lateral view. So after this, the examiner might ask you a different question, as in what are the grades of adenoids on an X-ray. Now, if you listen to a question like this, the student is definitely gonna be like confused. Okay, what could be the answer? So don't worry. If the examiner asks you about the grades of the adenoids, do not worry. Just listen carefully for this point. The answer to that question is, now first you have to locate the hard palate. You can see here, this is the maxillary bone over here. This is the mandibular bone over here. So you just have to locate the hard palate. This is the hard palate over here, and this is the posterior superior margin of the hard palate. This, as I was telling you before, that this is the area of the sella turcica. Okay, this is the area of the sella turcica. This is supposed to be the sphenoid sinus, and directly when you draw a line perpendicular in a straight axis, the adenoids should be right below. So whatever you see here is the adenoids. So always remember, there are three lines. Okay, three lines. Two you can see in the diagram over here, and the third one is along the skull base. So the first line for that, you have to remember, the first line is the A, the capital A you can see. That's the first line. Now this is the skull base, that's the base occiput. Okay, so that's the anterior inferior end of the base occiput, and this is the hard palate. You can see over here, that's the posterior inferior aspect of the hard palate, and this is the posterior superior aspect of the hard palate. So the first line, which is the A line, is from the base occiput and to this point. Or you can see here, this is the adenoids. Okay, this is the adenoids over here, the soft tissue of the adenoids, and this is the hard palate over here. So you see this margin, the maximum margin of the adenoids, you take the starting point as that's the maximum point of the adenoids up to the base occiput. So that's the line A. The second line you draw is from the posterior superior aspect of the hard palate right up to the, what is this point called as? Now this point is called as the sphenoido-base-occipital synchondrosis. Okay, sphenoido-base-occipital synchondrosis. So you draw a line up to there. Now you don't have to say all these words in the exam. You just have to remember that these two lines exist. Just say posterior superior part of the hard palate, the base occiput synchondrosis. That's the end line, and the A line is the base occiput to the maximum level of the adenoid tissue shadow. So what you do is, once you have these two lines, now the third line being the skull base, that's the base occiput. So what you do, you measure the distance of this A line, and you measure the distance of this N line radiographically. So what you do is you divide A upon N. So it's gonna be like A, this in the superior, and N in the inferior quotient. So you're gonna divide the length and you're gonna multiply that by 100. So you're gonna get a percentage, right? So that percentage, that very percentage, is also given by the quotient as L. Bejermy classification of the adenoid enlargement. So if it is less than 30%, it's considered to be as normal, so no surgery is needed. If it is around 30 to 50%, it's mild. The surgeon may decide not to go for an operation. If it's around 50 to 70, which is moderate, adenoidectomy is needed if there's symptomatic obstruction, that being nasal snoring and mouth breathing while sleeping. And if it's more than 70%, it's considered to be as the most severe form, and hence the surgeon will perform an adenoidectomy. Okay, so it's very crucial for you guys, if an examiner asks you on an X-ray how you can determine whether surgery is required or not, then this should be your answer. Well, you guys can take a screenshot of this theory of this photograph over here so that it can stay with you for a longer time. So you just have to read what is written over here, so you will remember that for a long time. So that is your X-ray nasopharynx for your adenoids completely for your exams. The second X-ray, this is the, suppose if an examiner gives you this X-ray. Now, well, it is very confusing. It looks very similar to a X-ray nasopharynx, right? But actually this X-ray is of a lateral skull base X-ray. That's the lateral X-ray showing the skull base, the cervical spine, the occipital bone, the maxilla and the mandible. So if you're in the exam, you just have to hold up the X-ray and say, this is an X-ray lateral view of skull base, occipital bone, showing cervical spine, maxilla, the mandible, the nasal bone as well, and the skull in majority. So basically what you can see over here is, you can see, I can just zoom this for you guys. What you can see over here, this is the area of the frontal sinus, the black shadow. Now on an X-ray, air looks black, bone looks bright white, and the soft tissue looks like gray. Okay, so whatever white you can see over here is the bone, the black is the air. So this is a frontal sinus. You keep following this, you can see this is a skull base, right? Above this should be the area where the brain is. This is the parietal lobe, this is the frontal, this is the parietal bone, frontal bone, this is the occipital bone, and to the sideways is the temporal bone. Okay, so this is a frontal sinus, following which this is the area of the ethmoid sinuses, the anterior ethmoids, the posterior ethmoids, and you can see this, you can see this a cup-shaped depression right here. That's the area where the pituitary gland is lodged, and it is called as the sella turcica. So this is the sphenoid sinus, and you can see posterior to that is the area of the TM joint, right? So another question the examiner can ask you in this situation is that locate the external auditory canal. So you're gonna search the entire X-ray, but you should know that the EAC, which is the external auditory canal, is this one, right? See, my cursor is pointing you towards the EAC. That's the external auditory canal, and just anterior to the external auditory canal, you can see over here is the temporomandibular joint, the condyle of the mandible. You can see this. This is the area of the external auditory canal. Just anterior to it is the temporomandibular joint. You can see this is the shadow of the mandible, and that's the condyle of the mandible, and this is the temporomandibular joint you can see over here. And just above is the superior anteriorly is the sella turcica. That's the entire structure you can tell the examiner. So if any question is asked where the EAC is, where is the temporomandibular joint, where is the sella turcica, trust me, this is a favorite question of the examiner, where he can ask you where is the pituitary stalk or where is the sella turcica. So also there's one more point left in this X-ray, is that whatever you can see over here, so it's very simple to remember. Anterior, first the main point is to locate the external auditory canal in any given skull lateral X-ray. So you locate the EAC, just anterior to it is the temporomandibular joint, and just posterior to the EAC is the mastoid air cells. You can see this huge structure of the mastoid air cells. That's the honeycombed appearance. Now I assume you must have seen the honeycomb, like the honey, the home, the hive of the honeybee, right? So it looks like a honeycomb appearance where there's a lot of air cells within, and this is properly pneumatized, so you cannot see any dense bone over here. So it is not sclerotic, it is normally pneumatized, and this is the area of the entire mastoid bone. So I'll cover up this area in detail in further Schuyler's view ahead. So if this X-ray is given to you, say that this is a lateral X-ray of the skull showing the frontal, the skull base, the pituitary, the mastoid, the mandible, the cervical spine, Okay, so this is how you will definitely identify all these structures in the x-rays for sure. So this is the same x-ray but in a different view. Now this is a proper x-ray which they will definitely ask you to hold up or give an answer for. So it's the same x-ray but a different view, so it's all same. This is the skull base, that's the U-shaped depression for sella turcica. This is the ESC. I'll just zoom in for you guys. As you can see, this is the sella turcica. That's the case of the ESC. But there's a difference in this x-ray. As you can see, there is no pneumatization of the mastoid over here. So there is absence of the honeycomb appearance, right? So what is this? This is a sclerotic mastoid bone. It may be because of chronic mastoiditis where the infection was so much that it has turned into fibrosis and it has given rise to a lot of sclerotic bone inside. So you can see there's no presence of mastoid air cells. So this is a very important finding where you guys have to locate. So you can see this is the mandible over here. That's the temporomandibular joint. Here is the ESC and the cervical spine behind. So if you study carefully and read the basics, I am so sure that you're not going to go wrong ever. So we did the x-rays, we did the x-ray nasopharynx for the adenoids, we did the lateral x-ray skull, we did the second version of the lateral x-ray skull. Now we're going to move on to the proper x-ray mastoids. Now I'll just zoom in this for you guys so you can take a screenshot of this. This picture is very important for you young students to understand. Now once you understand this photograph, trust me, it's going to be very easy for you, because whenever the examiner asks you to read a x-ray mastoid, normally the exam centers keep the x-ray Schuler's view. Now we are all very familiar with the x-ray Schuler's view, right? So the basic questions are like, what is the angulation? Where does the x-ray beam pass from posterior to anterior? What is the position of the patient in relation to the x-ray film? So these are only the basic questions which they're going to ask. So if you remember this photograph, it is going to be very easy for you. So as you can see over here, this is a Schuler's view over here. It is 30 degrees. So the angle made by, so just remember that this photograph, as you can see, now this is a proper one to take a screenshot. So yeah, so this is the orbit, and this is the patient is lying down parallel to the x-ray film, so that the orbitomeatal line is parallel to the film. This is a film, and the x-ray is taken from here. So the x-ray machine is here, the x-ray plate is here, the patient is supine, and this is the orbitomeatal line which is parallel to the film. So you shoot the beam from behind at an angle of 30 degrees. So as you can see over here, it's mentioned 30 degrees cephalocaudal. That's the Schuler's view for you guys. Now the same thing in this very picture, if you change the angulation and make it to 15 cephalocaudal, that same very x-ray is called as the Law's view. Okay, so these both are the lateral oblique views. Remember that these are lateral and oblique. See, they are not perpendicular, these are oblique. So these are oblique views and these are lateral to an angle of 30 for Schuler's and 15 for the Law's view. Now trust me, the examiners will give you a Schuler's view, but if the student is quite good and he is giving all the answers, they are definitely going to ask you all the other views as well. So you should be well prepared and should know all the views. So if we further continue, you can see this is the x-ray film over here, and this is the orbit over here, and this is a meatus. So this is the orbitomeatal line. This line is very important for the guys. Orbitomeatal line, and the x-ray beam is perpendicular to that orbitomeatal line and also to the x-ray film. So this is actually the most extreme view a patient can have. That is called as the submental vertical view, which is almost 90 degrees. That is perpendicular. So mostly used for skull base in the posterior cranial fossa, where you can examine the the foramen magnum and all the skull base foramens. the fourth one is the Townes view. Okay, so Townes view is same logic, but the X-ray beam is coming from the anterior to posterior, and the X-ray film is actually behind the patient. So what are we going to see is mostly towards the posterior aspect. So this concept is basically depending on the fact that whichever side is close to the X-ray film, the X-ray beam is going to reflect back from there, and so the area of the body which is in close relation to the X-ray film is going to be visualized on the X-rays much better. So always remember that the structures which are towards the X-ray film are visualized much better, and the one which is away from the film are visualized less. So this is a Townes view, 30 degrees. So if you remember this photograph for your exams, no matter what question the examiner is going to ask you, I'm so sure that you're going to be able to answer that. So the key is to remember only the angles 30, 15, 30 and 90. That's it, and the position of the patient. So let's move on to the Schuyler's view for that. Now, before going to the Schuyler's view, I would like to show you the Law's view. Now, as I said, Law's view is the lateral oblique 15 degrees, right? Now, oblique gives you an advantage that the both sides mastoid do not overlap each other. So you can see the mastoids of both sides actually. So what you can see over here, this is the area of the left mastoid, and the one below is the right mastoid. You can see the two ESCs. This is one ESC, this is the other ESC, this is the temporomandibular joint condyle, this is also a temporomandibular joint condyle. So this is a left TM joint, this is a right TM joint. You can see the shadow of the auricle over here, the ear canal, and both the sides are well pneumatized. You can see the proper honeycomb appearance. So you should remember all the anatomy, how to identify. Now, this is the diagrammatic photograph of the Law's view. So you can see over here, this is the Law's view basically. So the patient is lying lateral. As I said, the Law's view is 15 degrees. This is the angulation. The red line is for the Law's view, having a 15-degree angulation. This is a radiographic plate inferiorly. So the more you remember the diagrams, the X-rays, it's going to be very easy for you to remember that. So that was the Law's view. Now, the second, we should go for the Schuyler's view. Okay. Now, what is Schuyler's view? Now, this is Schuyler's view. To make it easy for you guys, the Schuyler's view is also called as the Ruggenstrom view. That's the area from where the X-ray beam is going to come, and at an angle of 30 degrees, it crosses the patient's head in a lateral oblique view and hits the plate. So you get a X-ray called as the Schuyler's view, which is also called as the Ruggenstrom view. So you can take a screenshot of this image right now. Yeah. So moving on to the Schuyler's view, this is the actual Schuyler's view. So if the X-ray is given to you by the examiner, what you have to do is just first thing is to identify the X-ray that sir, this is the X-ray lateral view of the mastoid, so showing the ESC and the mastoid area most prominently. So this is supposed to be the Schuyler's view. Now the examiner will ask you why Schuyler's. So you have to mention that the most prominent part here is the ESC and the mastoid over here in this region. So also this is a lateral view, and it's an oblique kind of view. So this is a Schuyler's view, and it is totally different from the lateral skull base X-ray which we saw earlier. So this is the most prominent part in this section. Now the second question the examiner may ask you for the Schuyler's view is that what is the importance of Schuyler's view? That is, why do you perform a Schuyler's view? Your answer should be in 3 points, 3 or 4 points to maximum 5 points. Now it depends on you guys how much you remember. The very first point should be to know or study the anatomy of the mastoid. You can see over here, this is the external auditory canal. You can see over here, that's the area of the pneumatized mastoid cells. That's the mastoid bone over here. That's few pneumatized cells over here. So the pneumatization is basically not complete in this patient. So you can say the aim is to study the anatomy of the mastoid cavity, whether the bone in the mastoid is pneumatized or sclerosed. So that's the first point. Second point is to know the anatomy of the dural plate and the sinus plate. So the dural plate should be above at this region. Okay, this should be at this region above, and this is a sinus plate. Okay, so sinus plate is nothing but it is posterior, dural plate is nothing but it's superior. So that was the second point, that is to identify the sinus plate and the dural plate. The first one was the anatomy, second is the sinus and dural plate, third one is to know whether there is any destruction of the mastoid by the cholesteatoma. So the third point is to locate the cholesteatoma. Yes, if the examiner asks you, can you see cholesteatoma in an X-ray? So you should say yes, cholesteatoma is seen on an X-ray. Then he will ask you how you can identify that. Your answer should be in simple steps, that cholesteatoma basically is seen as a soft tissue shadow, alternate black and gray tissue shadows. So there is a alternate hyperdensity and hypodensity, and you can see around that a thin rim of air foci, or you can say a thin rim of black shadow around a field of a gray one. So that is how you can tell that the cholesteatoma is present. Well, I cannot see the presence of a cholesteatoma. Somewhat it may be present in this patient, but not too much. So those 3 points at least you should remember, that if you asked what is the importance of Schuyler's view. Also, Schuyler's view, it does not overlap the two mastoids of the both sides, so you can clearly study the mastoid of the expected side. So that is Schuyler's view basically for you guys. Nothing else you need to remember in Schuyler's view. So moving on to the different one. This is also a X-ray Schuyler's view, but in a different perspective. Now what you can see over here is this is the ESC. Always look for the ESC first. Now that's the external auditory canal, and whatever you see here is the sclerosed mastoid. See, not a single pneumatization you can see over here. This area is completely sclerosed. So either this could be a case of chronic mastoiditis, you can see over here, that's the ESC, that's the temporomandibular joint. You can see now, you can see the entire mastoid sclerosed, completely white. There is no pneumatization whatsoever. So we learned Law's view, Schuyler's view. Now we come to Stenver's view. Now, screenshot of this right now. Okay, yeah. So Stenver's view is nothing but to keep it simple for you guys. Remember that the patient has a flexed head and a rotation of just 45 degrees, and the X-ray beam is angulated to 14 degrees caudal. Just remember the numbers, because there's a very slight chance that the examiner will ask you what is Stenver's view, but mostly they won't. But if asked, you should know what is Stenver's view. So Stenver's view is nothing but this, what you have, what you can see on this screen right now. So remember the degrees, remember the angulation, and remember the name, Stenver's view, which is nothing but the axial anterior oblique posterior. Very difficult to understand, I know, but just remember the degrees. That's it. It should be easy for you guys. So to make it more easy for you guys, if at all, now this X-ray I personally believe won't be asked for a MBBS student, but may be asked for a MS student, the one who's going for the MS examinations. So if at all you see any mastoid X-ray or a lateral skull base X-ray where you can see a lot of wires and devices, this is nothing but a device, cochlear implant, a hearing machine which has been implanted. So any X-ray which is showing all the cochlear devices or the hearing devices, it is nothing but always Stenver's view. Okay, so the Stenver's view mostly is concerned with visualization of the internal acoustic meatus, that is the internal auditory canal. Okay, so that is the importance of Stenver's view. Also, second, it gives a superior view for the superior semicircular canal. Okay, as you can see here, this is a superior semicircular canal over here. As you can see, this is a superior semicircular canal, so it's best visualized by the Stenver's view, and a lot of wiring. You can see the hearing aid, and this is also the area of the cochleostomy. So this is the Stenver's view for you guys. This is also the area of the Stenver's view. This is the area of the superior semicircular canal. So if you see a device, it is definitely a Stenver's view because it's aimed for that same reason. So the examiners won't keep any X-ray which is without a hearing aid device and expect you to say it's Stenver's. It is not like that. So this photo is again for your reference. So we studied Schuler's view, Law's view, then we studied Towne's view, then submentovertical view, Stenver's view. Now I'll show you the image for Towne's view. Yeah, it is. Now always remember, this is a Towne's view. This is how it looks like. So what you see is basically the back of the skull. You can see over here the foramen magnum, the dorsal sella, the occipital bone, the parietal bone. So if at all you get an X-ray which is showing you just the back of the skull with the foramen magnum in the lower aspect, definitely that has to be a Towne's view. And also the importance of Towne's view is to study the back of skull, and also it is the X-ray of choice to study the styloid process. Always remember that. It is a study of choice for styloid process. So always remember that the styloid process can be easily studied by this Towne's view. Okay, so that was all the X-ray mastoid part. And moving on to the next one, which is the X-ray PNS, that's the X-ray paranasal sinuses. So we have only two main common X-rays. One is the Waters view and the other one is the Caldwell's view. So this one is the Waters view in front of you guys, and this one which I'll show you, this is the Caldwell's view. So only two X-rays which are important, Waters view and Caldwell's view. Now to start off with, this is the Waters view. The question by the examiner will be, take this X-ray and tell me which X-ray is this. So your answer should be either you're holding the X-ray or you're pointing out the X-ray on a view box. The answer should be this is an X-ray paranasal sinus, Waters view, showing the area of the maxillary sinus, the frontal sinus and the orbit, okay, with mouth open. So that should be your answer. The second question from the examiner would be which sinus is mainly targeted in this view. So it is always the maxillary sinus. Now you can see over here, these two are the frontal sinuses and this two is the orbit, and in between the two orbits you can see the nasal bones, the midline septum, the bony septum, and on either side here you can see is the maxillary sinus. Okay, so this you can see, this is the open mouth. Now listen very carefully. The third question will be why this X-ray is called as the Waters view. Now just, you must have seen people drinking water, right? So whenever they drink water, they have to extend their neck and open their mouth. So imagine that position when the person is drinking water with mouth open and neck extended. So this is the same position for the patient for the X-ray. So hence it is called as the Waters view. The third question or the fourth question may be, why is the mouth open? Now if the mouth is closed, we cannot see something. If the mouth is open, we could see something. Now what is that structure? Now that is the sphenoid sinus. If the mouth is open, you can see the sphenoid sinus in this area behind the maxilla. Okay, so you can see the sphenoid sinus very carefully if the mouth is open. Now this is a diagrammatic picture which is showing you the axis of the X-ray beam. Now the fifth question in this X-ray is that many people don't know about this, but they do ask the angulation for this X-ray as well. So always remember that this is a radiographic plate in the front. The patient is facing towards the plate and the x-ray is coming from behind, that's posterior to the anterior. So this is the x-ray film, this is the patient's towards the x-ray film, this is the x-ray coming from behind, and you always follow the orbitomeatal line. So the patient is looking up and the mouth is open and as if he's drinking water, and so the main answer is the 45-degree angle. So we saw the all mastoid x-rays with their angulations. Always remember the Waters view also has an angulation of 45 degrees. Always remember that. Now, this is another x-ray of the Waters view, but in a different contrast. So what you can see over here, you cannot see the frontal very clearly, can you? No, you cannot. You can see the orbits very clearly, and you can see the part of the petrous behind the orbit. Okay, so you can see this is the inferior orbital rim, this is the nasal bony area, that's the maxilla, and that's the mandible with the mouth kind of open. So you can see the maxilla on both sides. It is not much clear. Now, if the maxilla were to be clear, it should be black, pitch black, like the orbit around here, but it is kind of hazy on both the sides. So this could be a case of a bilateral maxillary sinusitis with bilateral frontal, because neither the frontal or the maxilla is clear. So it is kind of a haziness positive in both the sinuses. Yet this is one more x-ray of the Waters view. Now as you can see over here, both the maxillas are very black, both the nasal cavities are black. So this mostly is a case of a normal patient without any maxillary involvement. Also the frontal looks kind of clear. So imagine if in the exams you're given the very same x-ray, but in the maxillary sinus there is some pathology present. Suppose if this is not black on one side, it is one side black and one side full of opacification, then it could be either right-sided maxillary sinusitis. Okay, the second case could be if there is a normal black shadow in the upper half, but the collection in the lower half. Yet another, it could be a case of sinusitis with an infection, active infection inside. Another case is that it could show a convex upwards margin like this. Follow my cursor like this. So if it's showing in the inferior aspect, convex upwards facing mass, that could be an indication of a retention cyst, or it could be a case of an AC polyp extending outside into the nasal cavity. If in another x-ray you can see a tooth in the maxillary sinus over here. Now normally we can see tooth over here, right? So we can see the teeth over here in this region, but if it is present in the maxillary sinus and you get the x-ray in the exam, you definitely have to tell that this is an x-ray of x-ray PNS Waters view, showing the maxilla with the hyperdense mass within, most likely to be a tooth, suggestive of a dentigerous cyst or a odontogenic cyst. So it could be a condition of a dentigerous cyst in the maxilla. So these are all the different conditions where the x-ray PNS can be really helpful, and you can identify them very carefully. So that was the x-ray PNS for you guys. Moving on to the one, this is a Carlwell's view. Now it's very important for you guys to understand all the angulations of these x-rays, because the examiner is basically going to ask you only the angulations and the indications of the x-rays, nothing more, because they also understand that you are in MBBS. So they're going to start off with easy questions. So you should know the easy questions like the angulations, the indications of the x-rays, the basic anatomy of the x-rays. So this one is the Carlwell's view, and this is mainly for the frontal sinus. So as you can see over here, the patient was here touching the chin to the plate and forehead was free. And in this section you can see the chin is free, and the forehead is kind of bending towards the plate, and the X-ray beam is coming like this at an angle of 15 to 20 degrees to the orbitomeatal line. So you always have to remember that the water's view was the angle of 45. The water's view had an angle of 45, and the Caldwell's view has an angle of 20. So always remember the mastoid X-rays and the PNS X-rays, they all have angulations. So Caldwell is nothing but mainly for the frontal sinus. You can see over here there is some kind of opacification in both the frontal, but the maxilla kind of looks blackish, so it looks normal, but mainly it is concerned for the frontal over here. Okay, so remember we have finished the lateral skull X-ray, the X-ray nasopharynx for adenoids, the mastoid X-rays, all of them, and the PNS X-rays. That is the main being the Waters view and the Caldwell's view. Okay, now this is very important for you guys to understand. Now this is an X-ray. Now I am so sure that you must not be knowing the exact name of this X-ray. You must be knowing this by the name of lateral X-ray nose, but that's incomplete. This X-ray is completely called as the dead lateral view of the nasal bone, also called as the lateral view in simple language. So if you're getting this X-ray in the exam, you should tell that this is a dead lateral view of the nasal bone, or simply the lateral view of the nasal bone. But if asked, it is dead lateral view. Now what you can see over here, this is a frontal sinus over here. You can see that's the frontal bone over here, that's the nasal bone, that's the nasal bone. So this part is a nasal bone, this part is a frontal bone, this part is the soft tissue of the nose, that's the LR cartilage. This is a nasal septal cartilage, this is a bony cartilage, this is a bony septum, this is a cartilaginous septum, and you can see over here there is a lot of fractures you can see in the nasal bone. Okay, I'll just zoom this for you guys. Now the first question is identify. Now it's very simple to identify that this is a dead lateral view of the nasal bone showing multiple fractures. Now you have to describe each and every fracture by showing multiple fractures. The above one over here, you can see this is the fracture which is minimally displaced fracture, linear minimally displaced fractures. Okay, and this one is minimally undisplaced fracture, linear undisplaced, and this is a kind of a depressive fracture. So for that you should know what type of fractures you come across. Now it could be a simple fracture, a compound fracture, a comminuted fracture, it could be displaced, undisplaced, it could be linear, it could be various angulated fractures as well, it could be a depressed fracture. So all these fractures you need to know in detail. So what you can see over here is you have to tell that this is a dead lateral view of the nasal bone showing multiple fractures of the nasal bone, this one being minimally displaced linear fracture, this one being linear undisplaced fracture, and this one being a depressed fracture. Now the next question of the examiner would be, what is the etiology of the nasal fracture? Now we all know that the fractures are most commonly seen in a fight, a road traffic accident, in cases of boxers where you get hit on the nose. Always remember that the person can get hit by two ways, one from the front and one from the lateral aspect. So the one from the front is causing a depressed fracture. So you can see this is a nasal bone, it will come like this posteriorly if it is a depressed fracture from front. If it's a lateral fracture, a lateral blow, it could cause a fracture and shift the patient nose towards the right or the left side. So you always have to look for the bony fracture as well as the cartilaginous fractures. Now what you can see over here, the blackish shadow over here, these are not exactly the fractures, but this could be the area of the grooves for the arteries, nerves, and the veins. So you cannot confuse them with the fractures. So the fractures look irregular and erythematous. So you can see a lot of fracture over here. So this is one X-ray for you guys. Now moving forward, you can see one more x-ray. Now this x-ray is a normal x-ray, okay? The purpose for me that you guys can understand the difference between the normal x-ray of the nose and the fracture x-ray of the nose. Now if this x-ray is given to you, you cannot see any fracture over here. See, this is a nasal bone, this is a frontal bone. You can actually see the suture between them. You can see this fronto-nasal suture. You can see the suture between them. That's the frontal bone, the frontal sinus. That's the nasal bone. That's the nasal bone, you can see. That's the cartilage. That's the groove for the nerves, veins, and the artery. So that's the normal x-ray for you guys. So you basically understand this x-ray, and then you can compare with the x-ray of the fracture. So it's very easy to understand what basically is the x-ray all about. So the next question of the examiner will be always, what are the types of fractures of the nasal septum? Now we talked about the fractures of the nasal bone. Now this is a nasal bone over here, we could see. So now we are talking about the fractures of the nasal septum. Now just remember, there are two fractures, okay? The one which is called as the Jarjaway fracture, and the other one which is called as the Chevalet fracture. Now the Jarjaway fracture is a horizontal fracture that is along the septum, and the Chevalet fracture is a fracture which is vertical to the septum. So these two fractures you should be very careful about. You should know these two fractures because these are common questions which they ask in the practical exam, as well as this comes as a short note for your MBBS exams. Now moving on to a different aspect of the x-ray is the x-ray foreign bodies. Now I'm just going to show you the x-ray foreign bodies in short. This is the x-ray, this is a foreign body bronchus, this is a foreign body bronchus, this is a foreign body esophagus, this is the foreign body coin, that is the esophagus, this is the esophagus, this is the AP and the lateral view of the coin, this is the same view but not of the coin but something else, I'll tell you afterwards. Okay. So there are many x-rays. Now it depends on the institute where you're studying at. Now they can keep any x-ray of the foreign bodies. It could be a foreign body bronchus, it could be a foreign body esophagus. You just have to know the simple tricks. Then come what may, you will be able to answer whatever questions they are going to ask you. So listen very carefully. So I'm going to clear all your doubts in this x-rays of foreign bodies because it's really important for you guys to understand that. Now, what is this x-ray? If this x-ray is given to you, what are you going to say? Sir, this x-ray is of a PA view showing the chest and the showing the chest region, okay, and the upper part of the abdomen with a hyperdense shadow in the x-ray, with a hyperdense shadow showing two prongs in the area of the mid chest. Okay, now this is only the PA view, right? And to confirm whether this is in the esophagus or in the the airway, you should always have a lateral view. But if in the exam, if this is the only view, how will you still identify? Now this is very important. See, follow the midline. You should always follow the midline. Now what you can see over here is a vertebral column, right? So you have to assess the area of the vertebral column that is supposed to be your so-called midline. So as you can see, this bone, this is a bony vertebral column. But what you can see for this foreign body is towards the lateral aspect of the vertebral column. So it is not in the center. Now normally the esophagus should be towards your vertebral column or slightly towards the left side, but this foreign body you can see here is towards the right side, and it is in a very slant position. The esophagus cannot accompany a foreign body which is this slanting. So it is very important for you guys in the exams to understand that whether this is an esophagus or the airway in this one single x-ray. So if you're given just this one x-ray, always remember that you have to know that this cannot be the one in the esophagus but one in the airway. As you can see the slight slant tilt, this first point, this is slanting, so this cannot be in the esophagus because esophagus is not that wide to accompany a foreign body this slanting. Second, it is towards the right side of the vertebral column. So if at all it is we have only one x-ray, you should be able to tell the answer that this is in the airway and not in the esophagus. So actually this x-ray is kind of difficult to assess, but following my points which I just explained, I think it should be really easy for you guys now. So what else? This is the second foreign body x-ray. Now the similar concept you have to apply here as well. Now what you can see over here is the hair clip, right? This is I think it's the hair clip or the pin which you use. So same thing, the same concepts apply here as well, that whether this x-ray is in the esophagus or the airway. Now it's common sense that esophagus cannot be this lateralized. Okay, esophagus should be in the midline following the vertebral column or slightly towards the left side, but never to the right side in this extent. So if you see a foreign body here, this is a lung shadow, you can see this is a lung shadow. So these are the bronchi, you can see the terminal bronchioles. So this could be one in the bronchi. So definitely this patient has a foreign body in the right bronchi, so and not in the esophagus. So these are the basic points which you can use to identify the exact location of the foreign body. Now the most important and the most common foreign body x-ray which you people get is this, is what is called as the safety pin foreign body. So the examiner is going to ask you, the first question is that identify the x-ray, now which everyone you can. Now the second question will be, he will ask you whether this is in the airway or the esophagus. Now as you can see, the foreign body over here is in the center midline, and you can see the black shadow over here, that's the airway. Okay, so the chances of this foreign body being in the airway is kind of less. Now also it depends on the history of the patient. Now if you are a physician or a surgeon in the OPD and you can see a patient coming, a small child with a foreign body in his throat or the esophagus or the lungs. Now if the patient is normally breathing, first point, if the patient is normally breathing, the patient is conscious oriented and not in pain, okay, it is definitely the foreign body has to be somewhere in the esophagus but not in the airway. Had the foreign body been in the airway, the patient would be gasping for air, the patient would have loss of voice or change of voice, or definitely he would be having cold clammy limbs, fall of saturation, he would be gasping, definitely gasping in the OPD. So that would become an emergency case. But if the patient is coming to the OPD walking by himself with normal respiration and no change in voice, or you can say a bit of discomfort in swallowing, that foreign body has to be definitely in the esophagus. So the history taking is also very important before the x-ray is done. So once you take the history, you should take the x-rays, and you should take the x-rays for both the PA view and the lateral view for sure. So in the exam point of view, you are given just this one x-ray, and yeah, as you can see, the x-ray is of a safety pin which is kind of open. Okay, the safety pin is open. Now this has a chance that it could be in the esophagus. Now as you can see, the open end must have punctured the lateral wall of the esophagus and has gone outside. So what in this condition, the question of the examiner will be, how will you treat this patient? It's a very common question. I have seen, I myself take exams in colleges in universities. So I ask the same question to every student, that how are you gonna manage this patient of an open safety pin. Now there are two answers to this. First one is that you can see in the x-ray, the safety pin is kind of open up and the open end is facing upwards. Okay, it's kind of facing upwards. Now there could be another scenario where this is the open safety pin, but the safety pin is facing downwards and has merged, or you can say pierced, the mucosa of the esophagus. Now for that there's an instrument called as the I can just show you here. Now this is the instrument I want to show you guys, and this is called as the Clerf-Arrowsmith forceps. You can take a screenshot of this now. Yeah, so this instrument is called as the Clerf-Arrowsmith forceps. I will zoom you the exact end of this forceps. As you can see, this is the forceps with two prongs and a steel guide in the between. So yeah, this forceps is basically used for removing this safety pin. So now in this case, the open end is facing upwards. So what we do is take the patient under general anesthesia. We hold the safety pin over here and we guide the safety pin downwards so as to remove the the submerged area into the lumen of the esophagus. Once we are sure that the esophagus is free of the safety pin, the pointy end is free, what we do is take the Clerf-Arrowsmith, we hold it near the open end over here so that it does not damage the mucosa anymore, and we come up. So by holding the safety pin at this very end, we come up. Now had this safety pin been facing downwards like this and submerged as well, what we do is pull the safety pin from this part. Okay, from this part we can pull the safety pin from this part. Now I can show you by inverting this. Okay, so it's very easy for you to understand. Imagine this is the downward position. So what we can do is come from here, pull the safety pin at this region, pull it up so that it is removed and comes in the lumen. We invert the safety pin, we invert the safety pin, we rotate the safety pin. So now it becomes like this, and now we then hold at the open end and then we come outside. So all this is done with the help of a esophagoscope for sure. So I hope this concept is very clear to you guys now. The name of the instrument, the procedure, how you deal with the open end, the closed end, if it is facing upwards, if it is facing downwards. Okay, so it's very important for you guys to know that. Now the second most important which we routinely see in our everyday OPD is a foreign body coin. Now also I'll just directly show you the AP and the lateral view. Now you can see this is a PA view. Just look carefully over here. This is a PA view of a smooth, so the x-ray, so you will say sir, this is the x-ray of PA view chest showing a smooth margin circular hyperdense foreign body, most likely of a coin, because coin is metallic and metal is bright white hyperdense on x-rays. And why coin only? Because it is uniform, it is smooth surface, the periphery is smooth, and it has no double density. Okay, you can see a uniform density, it does not have any other concentric rings around it, so it has to be a foreign body coin. Now the question is whether this coin is in the esophagus or in the the airway. Now very simple, you get a lateral view x-ray done and that will answer all your doubts. So as you can see over here, this is the lateral x-ray, and whatever you see, this is the nasopharynx airway, this is the oropharynx airway. They communicate and form a common airway. So wherever you see a black pipe like this, the black represents the air column, so this is the airway, and as you can see, it is miles behind the airway. Okay, so this is a foreign body over here, roughly at the level of C6, C7 vertebrae, cervical vertebra. So this is a first, second, third, fourth, fifth, sixth, seventh. So it is C5, C6, C7, T1. So mostly C7, T1 vertebrae around. So the examiner may also ask you the vertebral level. They may ask you whether it is in the esophagus or the airway. So to confirm that, we get a lateral x-ray done, and there we see that it is in the lateral aspect. It is in the esophagus. Now this is very easy concept for you guys to understand. Now the examiner can make it difficult for you guys, and then that difficult question can be, if they give you this x-ray of a PA view. Now if the patient comes in the OPD, okay, listen very carefully, this is a very tricky question, a challenging question. Now if the patient comes in the OPD with already an x-ray done from outside, okay, already an x-ray done from outside, and the patient has come to the OPD and the patient is not doing well, he is gasping for air, he is not able to speak, he's a small child, he's crying but the voice is very husky. So what can the diagnosis be? His saturation is falling rapidly, but the x-ray is showing this kind of a picture. Then what is your diagnosis? Then where your diagnosis can be? See, to explain you this concept, just imagine our vocal cords are, now I just have to show you guys. Now as you can see, I'll just show you with a diagram. Now as you can see over here, the vocal cords, see the vocal cords, if viewed from above, okay, the vocal cords if viewed from above, they look like V shape like this, okay. So this is the anterior end, this is the left vocal cord, this is the right vocal cord. These are the two vocal cords actually, two vocal cords. So left vocal cord and the right vocal cord, this is the anterior end, this is the posterior end. Now you know that vocal cords move and approximate each other, so they close like this and come close to each other. So if a small child eats a coin accidentally while talking, so in short he aspirates the coin. Now if the coin is going in the esophagus, how will the esophagus allow the coin? Now the esophagus is somewhat like this, okay. The esophagus, the cricopharyngeal sphincter is somewhat like this if viewed from above. So this becomes the anterior part and this becomes the posterior part. So if you get an x-ray done in a coin of esophagus, the coin will move, or you can say glide like this. See, this is a coin which I have drawn. This is a coin, okay. It's a very rough diagram, so please bear with me. So this is a coin entering into the cricopharyngeal sphincter, and hence when you get a x-ray chest, you see the foreign body like this, because it enters the esophagus like the same plane. But if the coin enters into the vocal cord and the vocal cords are like this in normal position, the coin will have to go like this in a erect position. The coin will go like this, right? I hope you guys are getting my point. Now the coin will go like this. Instead of going like this, the coin will go like this, like anterior posterior diameter. So if the patient is having a foreign body coin in the chest airway and the x-ray is done and the foreign body is in the airway, the same anterior posterior chest PA view will show a foreign body, but not like this, but it will show like this. So what I was showing you guys was see, so very same chest PA, but the coin will look like this. See, the coin will look like this on a PA view and not on a lateral view. So the coin will look like this on a PA view like this. So that means it has entered into the airway, and that becomes an acute emergency. So if this question is asked to you by any examiners, I hope now you can definitely answer the question. So this is a combined picture of the PA view and the lateral view, so make it easy for you guys. The next one, now see, in the exams, when the examiner wants you to fail, right, or wants you not to get good marks, what the examiner will do is that the examiner will give you the same x-ray mimicking a coin, and the MBBS student will be happy, and in excitement he will say, sir, this is a foreign body coin x-ray AP lateral view, and then he wonders why I was wrong. But if you look closely, I'll show you. If you look closely, does that look like a coin to you guys? Now, as I said, the coin looks spherical, smooth but uniform, and hyper dense bright white. Now, what you can see over here is that you can see the coin is uniform, and this you can see double density sign. You can actually see two rings in the outside. You can actually see two rings. I hope you can appreciate that. You can actually see two rings outside and not one single, and this is not that bright white. So what this can be, this is a foreign body battery. You see, this is 1 and this is 2, and there's a black line in between the two. So what this can be, this is a foreign body battery. This is a battery, a button battery, which you see in the video games and the remote controls. You can see a lot of see, this is one ring, this is the other ring, and there are two rings over here. So this is a case of a foreign body button. So this is also a case. The second question will be, is this a case of emergency or not? Now the examiner will ask you, well, this is in the esophagus, the patient can breathe, the patient has no danger. Is this case an elective case or an emergency case? Now what your answer should be? The answer should be, it is a case of emergency, because if the battery dissolves in 4 hours, it can actually melt the entire intestine or the stomach, and the patient may die of perforation. So you always have to remember this. Okay, now moving on to one more x-ray. Now this is an x-ray. You have to look very closely over here. You can see over here, this is the x-ray of a retropharyngeal abscess, or you can say prevertebral abscess. So mostly it's a case of a retropharyngeal abscess. Now there are 3 points how you can identify a retropharyngeal abscess. Now first of all, look at the vertebral column. See, the vertebral column looks straight. That is, there is loss of lordosis. So that's the first point. The straightening of the cervical vertebra is the first point. Second point is that, now you can see this is the anterior and this is the posterior aspect. This is the cervical vertebra body. This is the anterior border, posterior border, and this is the anterior posterior diameter. So this shadow over here you can see is the prevertebral soft tissue shadow, or the retropharyngeal soft tissue shadow. So if this width, or you can say the length of this prevertebral soft tissue shadow is more than 2/3 of the anterior posterior diameter of the vertebra, so this is the vertebra, so this becomes 2/3, so this becomes 2/3. If it is more than that, you can see definitely it is more than that. It is definitely a retropharyngeal abscess. Okay, it is definitely a retropharyngeal abscess, a prevertebral abscess. So the third point is that you definitely have to see for, you can see over here the anaerobic gas shadows. I'll show you. You can see this is multiple foci of black air foci over here. That is indicating an anaerobic infection, active anaerobic infection. You can see this is all black shadow over here. That's the air foci. This is gray and this is black. So this is the third point. So whenever these 3 points are in an x-ray, you should say that it's a retropharyngeal abscess. Okay, so this is a very common x-ray which is kept in the examiner's room, and they will definitely ask you that. So this is also a same x-ray. This is, you can see this is a normal airway. This is the area of the esophagus, that's the pharynx, so a retropharyngeal abscess. You can see that more than 2/3 of the anterior posterior diameter is, obviously it is more than that. There is straightening, somewhat straightening of the cervical vertebra, and I can see this is a black air foci here. So all 3 points are satisfied. This is a retropharyngeal abscess. Okay, now this is an x-ray of a barium swallow. Now whenever you get such x-rays, you always have to say that this is a lateral x-ray of a barium swallow showing a hyperdense fluid attenuate fluid shadow in the so-called area of the esophagus. Okay, so whatever you can see over here is the contrast which is used in barium swallow. So the questions may be asked by the examiner that what are the indications of barium swallow, what is this condition we can see in this x-ray, what are the contraindications of barium swallow, what is the contrast used in the barium swallow, what are the alternatives or the different options where you can use a different contrast agent in case of a esophageal perforation or a tracheoesophageal fistula. So the first question answer is this is an x-ray barium swallow lateral view, and this condition which you can see, this is esophagus over here. Now obviously the patient has to swallow the barium swallow, right? So where will it go? In the esophagus and nowhere else. So this is esophagus, but you can see something posteriorly and outpouching. This is nothing but a Zenker's diverticulum. Now the question may arise, what is Zenker's diverticulum? Now it is a pulsion diverticulum. Now there are two types of diverticula, a tractional and a pulsion. This is a pulsion type, and this is because of the weakness in the posterior pharyngeal wall called as the Killian's dehiscence. Now Killian's dehiscence is because of the weakness in the area formed by the cricopharyngeus muscle, the horizontal and the oblique fibers. So it causes a weakness in the posterior pharyngeal wall, and it forms an outpouching, or you can say inpouching, called as a Zenker's diverticulum. So the food may get trapped in this pouch and may cause halitosis, infection, abscess formation. So what is the contrast used is the barium for sure, and it is a high molecular weight. What if it's a case of what are the contraindications of barium swallow? Now there are two main contraindications. You have to listen very carefully. The first contraindication is the tracheoesophageal fistula. The second contraindication is esophageal perforation, because if you use barium swallow in perforation, it will enter into the peritoneal sac, the cavity. It may induce a anaphylactic reaction and the patient may die. So in that case, what is the question? What other solution you can use? You can use a low molecular weight, non-ionic contrast, mostly iohexol. So you can cross-check it with the surgery reference. So a low molecular weight, non-ionic, low molecular weight you should use. So that is as compared very safe and non-allergic. Okay, so it is compatible. So this is for the barium swallow for you guys. Now this is a normal X-ray skull transorbital view. Normal, this is mostly used for the orbital pathologies. You can see the nasal septum, the maxilla, the frontal. Now the frontal looks to be very opacified along with the left maxilla, so suggestive of the maxillary sinusitis. So this X-ray is a very common X-ray. You just have to see, this is the all sutures which you can see over here. You just have to mention the sutures, the orbital plate, the zygomatic bone, the maxilla, the mandible. There's nothing much to say in this X-ray though. Now this is a very important X-ray over here. Now this X-ray is a posterior anterior view of the neck along with the upper chest, showing the airway column over here, which is having a narrowing towards the upper aspect. This is a typical sign called as the steeple sign. Now why is it called as a steeple? Because you know that steeple is something which you can see at the top end of the church where it narrows out. So this is called as a steeple, or also called as the pencil point X-ray finding. So this is mostly seen in croup. Okay, so this is mostly seen in croup, laryngotracheobronchitis. Now this is another X-ray of the same thing, that you can see this is a subglottic narrowing of the airway of the trachea. So you can see this is a steeple sign or the pencil tip point. This is one more X-ray you can see here. Now this is a normal X-ray neck lateral view, but what is this arrow showing towards? Now as you can see, this is the epiglottis, And what does it look like? It looks like a thumb, right? So it is also called as a thumbprint sign, and it is commonly seen in epiglottitis. Now I'll show you a normal x-ray for this condition. Now see, this is a normal x-ray neck lateral view showing the cervical spine. This is the hyoid bone over here. That's the thyroid cartilage. That's the airway. That's the mandible. That's the cervical vertebra. That's the basi-occiput mastoid. So this is the hyoid bone, thyroid cartilage. And what you can see over here, I'll just zoom this for you guys. What you can see over here is, this is the hyoid bone. That's the thyroid cartilage. And you can see over here, that's the epiglottis. So that's the normal epiglottis. But in case of epiglottitis, you can see this becomes like this. This is the hyoid bone over here. That's the thyroid cartilage. The same structure has become so edematous that it looks like actually a thumb, and hence it is called as a thumbprint sign or the thumb sign, which is seen in the epiglottitis. So I assume this is all the x-rays you can see in an ENT exam or the ENT postings. So I think all the concepts of the x-rays are done and all the anatomy is explained. So in next videos, I'll be uploading all the surgical instruments of the tonsillectomy, septum, mastoid. So whatever surgery instruments that come in your exams, I'm gonna teach in detail. So just keep subscribing, keep learning, and see you soon. Thank you.